All right, thank you so much, everybody, for joining. It is January 31st, 2024, not 2023, if you can believe it. Today's presentation is hosted by Dr. Marnie Walston. Go ahead and go to the next slide. Dr. Walston has no disclosures. You can go to the next slide. Please note, the views and opinions expressed in this presentation are those of Dr. Walston and do not represent official policy or position of the Ohio Department of Health. We can go to the next slide. This training is hosted by the Ohio chapter of the American Academy of Pediatrics under the Parenting at Mealtime and Playtime program. In its 20th year of funding, Parenting at Mealtime and Playtime has provided evidence-based education to physicians, nurses, home visitors, community health workers, and beyond. Tackling a myriad of topics, this year, PMP will discuss breastfeeding, creative ways to bolster nutrition, and today's topic, how to navigate difficult weight-related conversations. PMP handouts can be found on the Ohio AAP website, linked to this QR code. The handouts are designed for caregiver and child use and provide information on various topics. Next slide, please. The PMP toolkit has been designed with physicians in mind and is linked to this QR code. The toolkit has resources on how to increase your practice's presence on social media and common EMR phrases when working with a pediatric population. Next slide, please. The PMP website has recorded trainings on supportive clinical spaces and engagement with patients living in larger bodies and motivational interviewing. The Ohio AAP's Instagram, which will be shared shortly in the chat, shares short educational videos for a broad audience. The Ohio AAP is excited to continue the work of PMP and looks forward to diversifying its audience and topics. If you have any ideas for the toolkit or mobile app through today's session, please share your ideas in the chat or reach out to myself, Sahavi, the PMP program manager. We always appreciate feedback from our learners. Next slide, please. Throughout the creation of these slides, Dr. Walston has considered the Ohio AAP's DEI inclusion standards and invites your feedback at her email below. Next slide, please. With that, today's training is hosted by Dr. Marnie Walston. Dr. Walston is a pediatrician at Akron Children's Hospital. She earned her medical degree from the University of Toledo's College of Medicine and has completed her residency in pediatrics at Nationwide Children's Hospital in Columbus, Ohio. She has been in practice for over 8 years and is board certified in general pediatrics and obesity medicine. Her clinical interests include caring for children and adolescents with obesity and providing medical management for pediatric bariatric surgery patients. Thank you so much, Dr. Walston, for being here today.
Thank you, Sahavi. I'm happy to be here and grateful to the Ohio AAP for asking me to come and share this presentation. I know this is a topic with a lot of interest, and it's something that's very near and dear to my heart because, as Sahavi mentioned, I've dedicated my entire post-residency career so far to caring for patients and families with obesity. And so I don't necessarily want to market myself as a communication expert, but I have had an abundance of opportunities to practice these uncomfortable and difficult conversations. And I'm grateful because my patients have been very generous over the years with giving feedback to myself and my team if we're doing something well, but even more importantly, if we are doing something or saying something that rubs them the wrong way or they don't like, they really share that with us too. And so that's helped to inform this presentation for you today. So we'll kind of, I'll talk from that base of experience, but also share with you what the literature tells us, because this is a subject that has been researched and written about quite a bit as well. And I will say, if you're interested, if anything that I say today kind of, piques your interest and you want to learn more, there's several papers that I've cited through these slides that are really excellent resources. They're easy to read. They're all relatively short, and that could be an excellent resource to continue your learning and thinking about this subject. It's really no surprise, though, to any of us that talking about weight is uncomfortable and unpleasant. It is in our personal lives, and then especially when we're talking about overweight or obesity, and we're talking about children, this can be even more difficult. And there's a general reluctance to raise the topic of overweight or obesity during clinical encounters, both on the part of healthcare providers as well as families. So, healthcare providers, when surveyed, say that the primary reason that they would not raise this topic during an office visit is because they're afraid of offending their patients. And this was especially true when the healthcare provider thought that the patient or family might not yet know that the weight was a concern. Providers say that they also avoid these conversations because they feel unprepared. They feel they have insufficient training on obesity and they lack knowledge of referral pathways for their patients. So they don't really know what to do with it once they've diagnosed this problem. And then finally, some providers said that they would avoid raising the topic of overweight or obesity simply because they lack confidence that there's effective treatments for their patients. And this was especially true if the provider felt that the patient had kind of an unchangeable factor contributing to their weight. So perhaps a physical disability or limitation that prevented exercise, or a patient taking a necessary medication that led to weight gain. In those cases, providers felt bringing up the weight was futile because there might be nothing helpful for the patient. On the other side, families also say that they are hesitant to raise this topic during visits with their children. And that primarily stems from previous experience of disrespectful treatment and negative attitudes of healthcare providers, either toward the patient or possibly toward the family, the parents themselves. Parents also said that they were concerned about damaging their child's self esteem or promoting eating disorders. They were worried about body image. And then they said that they often leave these consultations feeling blamed for their child's obesity and with feelings of guilt, shame, and humiliation. And to me, this last part is really what kind of strikes a nerve and tells us how important it is that we do spend time preparing for these conversations and making sure that we are being sensitive and using some evidence-based good communication skills, because none of us, I'm very confident, none of us want to make our patients feel guilty or ashamed or humiliated in the course of providing them medical care. But we know that this is happening. And one way that we know this is happening is by looking at patient satisfaction scores and patient comments that are received through things like the Press Ganey surveys that go out after visits. And I would guess that maybe a handful of you are here today because maybe you've been on the receiving end of a patient comment where you could tell that the family didn't appreciate the way that this subject was raised or discussed in the office. I know at my institution, we, over the recent years, have had some initiatives to increase the ordering of labs for children with obesity, or to properly put BMI categorization on the problem list. And while these are very positive QI projects and they kind of force the subject of obesity more often during office visits, we also saw with that an uptick in these kinds of negative comments from families. So we can tell that not all providers are prepared to have these conversations. I'm going to read for you just a couple of the comments that were received by providers at my institution to demonstrate how families are sometimes receiving this information, their perception of it. And right now we'll just read through the comments, but then we'll revisit them at the end of the talk and see, kind of using some of the tips and tools that we talk about, how the provider might have used some different techniques and perhaps the conversations would have gone a little bit better. So the first patient comment: we have a healthy, well-rounded, smart, capable, high-achieving child who eats healthy, has a 4.0, and is a standout athlete who is active 6 to 7 days a week. Every single time we see this provider, it is uncomfortable for my child and as a parent. She preaches, lectures, does things that make my child uncomfortable. This care provider needs to work on her tone and relationships with parents and children. She is flat out rude and gives my healthy weight child body image issues. I would be very happy if we did not ever have to see this provider again and if she left the office. Every single interaction is unpleasant. Okay, next. The provider made my daughter cry the entire appointment. She is 11 years old. He told her she was overweight, and that is how kids start to have eating disorders. So unprofessional for him to say in front of a child. If he had serious concerns, I should have been spoken to in private. He made my daughter upset, embarrassed, and uncomfortable. I will never use him as my child's doctor ever, nor recommend him, especially for girls. And last, I don't appreciate my daughter's perfectly healthy weight being discussed in front of her like she's 600 pounds. Not every person fits into your BMI box. She's nearly 5 feet tall, she eats well, and is active, so the constant harassment about her weight is getting old. So, as you listen to those and take a look at them, you can see that this is obviously a very emotional topic. These families left with a lot of feelings of anger, and they're citing specifically those worries about self-esteem and body image and embarrassment and how uncomfortable this conversation is. When I read these comments too, I read it from the point of view of the healthcare provider, and I immediately kind of want to jump to their defense and say, your daughter's weight is not a perfectly healthy weight, or else this conversation wouldn't have been brought up. But I think that further points out that this is such a emotional and stressful topic for these families that the main message that the provider was trying to deliver didn't even land, right? They weren't even able to see that concern that perhaps their child's weight is too much for their health or that it is causing, current or future health risk. Instead, they kind of had a stressful emotional response and weren't really able to take in that information in a way that was useful to them. So none of us want to get comments like this. And I think for most of us, it would be pretty upsetting to know that that's how our families received this information. And so what can we do to help? I've tried to pull out kind of 5 specific tips that you can use for navigating these difficult conversations. And the first 2 I consider like pre-homework to do kind of before the visit to improve your comfort with these conversations. And then the other 3 are really practical tools that you can use. You can start, trying them tomorrow if you'd like. And I think you'll notice that they help these encounters to go better. So we'll talk about each of these in turn, but we're going to talk about improving generally your knowledge about obesity and available treatments, as well as local referral pathways. We'll talk about taking a moment to examine your own personal biases about obesity and considering the way that that may affect your communication with families. I suggest that when you are bringing up this topic during an office visit, you first ask permission before addressing the weight. And then we want to be sure that when we're talking with our patients, we use what is considered patient preferred and non stigmatizing language. And I have specific examples for you of what that is. And then the last bullet point, of course, can apply to anything that we do with our patients. We need to listen to them and we need to believe what they tell us and then try to create individualized care plans. And the key here is to try to avoid sometimes giving cookie cutter advice that we might give to any patient with obesity and really try to engage them and help them. So we'll kind of talk about what that looks like later. Going back to the first bullet point, though, it is really no surprise that providers feel unprepared to tackle obesity because when most of us were in medical school or in training, obesity was not a part of the curriculum. We weren't taught that obesity was a disease and we weren't taught what the available treatments were. Most of us simply learned that obesity was a risk factor for cardiometabolic disease and a lot of other specific conditions. And we knew that we needed to help our patients lose weight, but we didn't get much guidance on how to do that. Thankfully, we nowadays, obesity is being incorporated into a lot of medical training and curriculum, and our view has changed so that we really see this as a complex chronic disease. And we recognize the multifactorial contributors to obesity. It is more than a lifestyle problem or a behavior problem. We know that there are genetic and physiologic and environmental and socioeconomic contributors that all play a role in our patients' obesity, as well as behavior and lifestyle things. And so, I would definitely encourage you. I wanted to call attention to the AAP Clinical Practice Guideline on Evaluation and Treatment of Pediatric Obesity. I still feel like this is new when I talk about it, but we're really coming on the 1-year anniversary of this document being published. But this is so important and so helpful. It's really the first time that the AAP has given us an evidence-based clinical practice guideline for obesity. Prior care was guided by expert opinion and expert committee recommendations, but this new document is thoroughly researched and evidence-based, and it's really helpful if you're feeling any hesitation about how to manage this disease in your practice. It's very easy to access at the AAP website, aap.org/obesitycpg. And not only will you get the actual clinical practice guideline document there, but there are lots of algorithms and practice implementation tools and resources that you can use in your clinic. And as you look at this guideline, you're also going to be able to read about the evidence-based effective treatments for obesity. And I think that's the important word, is effective. We know that these things can work and that engaging in obesity treatment is not futile for most patients. That first one there, intensive health, behavior, and lifestyle therapy, is of course the cornerstone treatment that all patients with obesity should be offered. But for some patients, considering weight loss medications and bariatric surgery may also be appropriate. And so it's important to know about those treatments, and lots of elements of obesity treatment can be initiated by the primary care doctor in the primary care office. But some of these will be better delivered by a multidisciplinary team, perhaps at a tertiary care weight management clinic, some of our hospital-based programs. And so since this is a talk for providers from across the state of Ohio, I haven't listed specific programs here, but I would encourage you to, if you don't already know, find out if you're near a children's hospital here in Ohio, find out what their obesity medicine program is called and how to refer to it. So we're not usually called the Obesity Medicine Clinic. That's just a little tip for you. Here at Akron Children's Hospital, it's the Healthy Active Living Program. I did my training and worked previously at Nationwide Children's Hospital in Columbus, where it's the Center for Healthy Weight and Nutrition. So learn what your program is called and what elements it has. Does your nearest hospital or weight program offer adolescent bariatric surgery? If not, find out where the nearest place you could refer your patients to access that treatment might be. Also, you can look at things like clinical nutrition. How can you refer a patient to see a dietitian or for physical therapy? Especially if you're a little bit farther away from some of these large children's hospitals and your families may not want to travel. You may have some local healthcare-based resources for them. And then also looking to the community can be really helpful. So YMCA programs, for example, there are often programs at the Y that are focused on helping kids with a higher body weight, and they incorporate both nutrition and activity. You can also look at things like the Big Brothers and Big Sisters programs. That might be a way to get some structured activity for kids after school. Knowing about youth sports in your area, Special Olympics for some of our patients, those can be helpful things that you can then tell your patients about to try to engage them more in these kinds of treatment. Once you've kind of brushed up on your obesity knowledge, the next thing that we should do is to take some time to consider what our own personal biases about obesity and weight may be. With the understanding that most of us probably do enter this conversation with some degree of bias. Weight bias is pervasive in the United States, and it starts very early. So research studies have shown preschool children as young as 2 years old already displaying weight bias. And we know that healthcare providers and physicians are not at all immune to this. Research has looked specifically at MDs with explicit and implicit bias in mind and found that they displayed levels of weight bias that were equal to the general public. And then a separate study looked at physicians in training and found that their level of explicit weight bias actually worsened or increased over the course of their medical training. And we know, that this can be very problematic because if we hold these negative attitudes or stereotypes about obesity, that will inevitably impair our communication, and it can really worsen patient-centered communication. And we know that that leads to worse physical health outcomes as well as mental health outcomes. So when that patient-centered communication is impaired, there's actually a 19% higher risk of patient non-adherence and mistrust of the provider. And when we look specifically at weight loss, patients who feel that they're biased against or who experience weight stigma actually have worse weight loss outcomes despite being involved in treatment. And it's been proposed as well that patients who are victims of stigma, whether it's racism or weight stigma, they may have a physiologic response where they have an increase in cortisol that can worsen their cardiometabolic health and lead to weight gain. So it's important that we confront this topic and then do what we can to address and at least be aware of our own biases. And so explicit bias is easy to detect. It's conscious. We are aware of it. It often reflects our own beliefs about certain groups of people. And it does affect our communication in very clear ways. It affects our verbal communication. It affects conscious decision making. And there is, a high amount of explicit weight bias, even amongst healthcare providers in the United States. Those who have higher levels of explicit bias are also those who are more likely to say obesity is a behavior and lifestyle problem, and not to necessarily acknowledge all of the other genetic and biologic and um, socioeconomic and all those other factors. So it's possible, that if you do kind of try to spend some time learning more about obesity and recognizing those things, that can help to reduce some explicit bias. Implicit bias, on the other hand, is harder to detect. This is more of an automatic response. It's unconscious. Sometimes or often implicit bias is directly at odds to somebody's own values or personal beliefs. But nevertheless, it will affect our nonverbal communication, actions, and especially decisions made under cognitive burden. And we know that healthcare providers make a lot of decisions under cognitive burden. So, how can you know if you have implicit bias? This is actually something kind of fun, and I'm sorry I didn't get the website for it onto this slide. But if you haven't heard of it before, there's a website you can visit called Project Implicit, and the website is implicit.harvard.edu. And this has been around for a long time, so some of you may have visited it. It's essentially a research project collaborative between Harvard and UVA and another, I forget the other institution that's involved. And they're looking at the effect of implicit bias on social behavior. But what you can do when you go to this site is they have a weight test, but they actually have, I think, 19 total tests that are implicit association tests you can take to see where you fall as far as having an implicit bias toward a condition, whether it's weight. They also have tests for gender and race and political affiliation and a whole bunch of things. But it's kind of fun to take that and then see what your results are. And in the effort of full disclosure, so I did this years ago, and then I went and revisited it just like 4 months ago or so. And I feel I am an obesity medicine trained physician. This is my entire patient population. I have a very good understanding of the complexity of this disease and the difficulty of treating it. I have friends and colleagues and family members with obesity. So I don't think I harbor explicit bias toward obesity, but on the implicit bias test, my results come back with having and I'm going to say it exactly like they do, a moderate automatic preference for thin people compared to fat people. And that's the second to the highest level of implicit bias. So that personally, it upsets me, it bothers me. I'd like to be in the neutral category, but it's not uncommon. So when you look, I think it's something like 28% of the more than 1 million people who have taken this test end up in that moderate automatic preference for thinness over obesity. And then 31% of people actually have a more strong implicit bias. So that's the highest category, are those people with a strong implicit bias of thinness over obesity. So we know that this is super, super common. It affects all of us. And being aware of that can help us to really take time to consider both the words we use in our verbal communication as well as our nonverbal cues and the decisions that we make in healthcare. Because again, if our patients perceive that they're being biased against or feel that they're victims of stigma, we know that that has really negative health outcomes. Okay, so that's kind of the pre-homework. Now, how about when we get into the visit? So how do we start a conversation about weight? It's really important that we start a conversation about weight in a way that demonstrates respect for your patient's preferences and helps to build trust with your patient. And our patients do usually have preferences in how they would like this topic addressed. Research tells us that amongst families with children with overweight or obesity, about 2/3 of the families prefer that the topic of obesity be raised with their child present in order to convey the importance. But conversely, about 1/3 of families prefer that the topic not be raised with the child present. So they may be okay discussing this, but they don't want to do it in front of their kid. And out of those people, a chunk of them said that they were primarily concerned about lowering self esteem and increasing the risk of eating disorders if these conversations occur with the child present. Some families also said that they don't want to discuss weight at their first meeting with a clinician, but they would prefer to have a relationship with the provider first. So, how can we know? How do we know where our families are on this and what they think? And the simple answer is to ask permission before we discuss the weight. And when we do that, it gives our families an opportunity to fill us in on what their preferences are. And there's actually something else I want to highlight that we should do before we ask permission to talk about weight. And that's that we need to make sure we have addressed the patient or the family's main health concern first. So, what brought them into your office on that day? Make sure that you have addressed that fully to their satisfaction before you ask permission to talk about the weight. Patients with obesity, both in pediatrics and in the adult world, report that healthcare providers often dismiss their primary concerns and they focus only and always on the weight. And that's something that really erodes patient satisfaction as well as trust. So, how do you do it? It's really simple. You can just say, would it be okay if we talk about your child's weight today? And it's amazing actually how much more comfortable that will make you and the family because chances are they're going to say yes. I mean, it's pretty rare that they will say no. And once they do say yes, you're no longer kind of catching them by surprise. They're acknowledging it's okay to move forward with the conversation. And if you have time and feel comfortable with it, a great next step to ease them into this conversation is to ask, how do you feel about the weight? That lets you right away judge what their perspective is, and then you can frame your further conversation based on the patient's perspective and concerns. Now, what about when they say no? Because that will happen. They'll definitely say no at times. It's really important to respect their choice. If they say no, it's not okay to talk about weight today, you can move on. You don't have to do it. You can feel free of the burden. It's absolutely not necessary to address overweight or obesity every time you see a patient. And I know sometimes we feel that we should because we think it's a primary risk factor or something that's affecting their health, but it is okay not to talk about it every time. And especially if the family declines and says, no, we want to respect that choice. It is okay to say, would it be all right if we revisit this topic at a future meeting? And sometimes they may say yes to that. Also, if they say no, keep listening because they may give you some of this information. They may say, I don't want to talk about it while my child's here, but can we talk about it in private or another time? Or they may say, I don't want to talk about it today, but I'd be okay discussing it with our regular doctor. So maybe you're somebody who's filling in or seeing them for a sick visit. And if they give you those kinds of indications, I would encourage you to try as much as you can to accommodate the request. So if they say, not with my child present, maybe it's something that right there in the office you can find a way to talk to them in private for a little bit, or maybe it means a phone call after the visit. But that will really help everybody to be more at ease, and you're much less likely to get those kind of feelings of anger and upsetness if you can accommodate that request. And if it's that they'd rather talk about it with the regular doctor, you can offer to help set up an appointment to do that or send a message to their doctor. Um, but most of the time, you'll get a yes when you ask permission to discuss the weight, and then you can kind of move forward with the conversation. And so The next thing to consider when you're starting this conversation is language. When we talk to patients about their weight, the words that we choose are extremely important. The language that we use can influence how much our patients trust us, as well as how comfortable they feel discussing the weight. And a lot of terms that we use to discuss weight, some that I've used numerous times during this presentation, patients consider to be judgmental or offensive. So the primary example here is obese or obesity. I've probably said it, 50, if not more times during this talk so far, but it's a word that I almost never use in the exam room with my patients or when I'm talking to them. And that's because when patients hear obese or obesity, they're not thinking like I may be about a clinical diagnosis or a certain BMI threshold or even that kind of cardiometabolic disease. When patients hear the word obese, they associate it in their mind with things like laziness, gluttony. I've had patients say that's disgusting. Obesity means disgusting to them, being weak willed. And so, if we use that word in the office, it can be very offensive and off putting to patients. Research has been done to look at this. And so the table that you can see here is from a study where they asked adults, adolescents, and parents of younger children with obesity, what words do you want to hear when you're having these conversations? What's your preferred language, as well as what language do you dislike? And you can see across the board, obese and obesity is disliked. Fat and fatness as well. In fact, that was the least liked term. It caused the most stress. It caused patients to feel the most blamed if you used fat. And then obese was kind of second on that spectrum. But also even things like large size. And for the younger children, even overweight was listed on the disliked language. I found a separate resource where the word chubby, was repeatedly categorized as disliked language amongst parents of younger children. And many providers, may think that's fairly benign, but families don't like to hear that. What they do want to hear differs a little bit by age group, but adults were comfortable when we talked about weight and BMI. Adolescents with weight problem, even enough people to get it on the list said that plus size was an okay term to use in talking about their body and their weight. And then parents of younger children preferred to hear that their kids were gaining too much weight or had too much weight for his or her health. And that's the kind of language that will feel less judgmental and blaming to our patients. The bullet point at the top there as well is important. And this is, I think, is more so when we're talking to our colleagues, when we are talking to our trainees, like medical students and residents, or when we're handing off a patient to another provider. It's important too that we use person first language. So we talk about a patient with obesity and not an obese patient. And the reason for that is because this really gives respect to the person who has a condition or a disease, and it doesn't define or label the person by this disease that they have. And so that's something, once you get practicing it, it gets really grating to your ears when you hear someone say, this is an obese kid or an obese adult. We really, it's much more respectful to talk about a patient with obesity. Okay, so the last bullet point I have here, and I really could have had a better title for this, which is essentially use motivational interviewing. I can't highlight enough that motivational interviewing is an evidence-based effective tool for obesity management. And what that means and what that looks like is what I tried to kind of lean into here on this slide, which is that we want to, once we've brought up this subject with our patients, we really want to listen to them and hear what they have to say, both in their perspective about the weight, but also we want to ask open-ended questions and inquire as to what they're doing with their activity and exercise and nutrition patterns. And we really want to stay away from making assumptions. So it is a tendency for all people and healthcare providers too to assume that all patients with obesity are overeating and that they're not exercising. And I can tell you that that is absolutely not true. This is such a complex disease with such a spectrum of causes and contributors that you will have patients who are exercising 7 days a week and they still have obesity, or who are really not eating very much at all. And if we make those assumptions and they kind of feel that, then they feel like we're not listening and they feel judged and they trust us less. So we want to use those open ended questions, maintain a respectful tone, try not to be judgmental. And then, in the spirit of motivational interviewing, you want to provide gentle encouragement and try to nudge your patient toward specific and individualized goals that may be helpful for them. It's also useful to try to shift away from weight management to thinking about health management, because that gives you so many more goals and targets and ways to measure improvement than if we're just looking at trying to lose weight or to the number of pounds that a patient has. There are so many ways that you can practice MI. I'm not going to talk about it in a whole lot more detail, but the AAP has wonderful resources for this. The AAP Change Talk is that virtual simulation for practicing MI. The Obesity CPG discusses the use of MI for obesity. I think it's even a part of this parenting at mealtime and playtime curriculum to be able to help provide more skills. And a lot of people say MI takes too long, it's too involved, but even just evoking the spirit of MI and trying to let it guide, the way that you speak with your patients leads to a lot more satisfaction on both the provider and the patient side. And I can almost guarantee that if you do this, it will help your patients to feel more heard and more comfortable. The other piece of advice here, when we're talking about individualized care plans, is I would really encourage you to try not to jump immediately to giving what we will call kind of cookie cutter advice. A lot of us want to do this because our time is limited and we want to give our patients something that's really high yield that they might be able to use to help them. So we're tempted to give handouts or right away start saying, certain habits that they should have. A lot of people know about the 5-2-1-0 concept. So we should have 5 servings of fruits and vegetables each day, 2 hours or less of screen time, 1 hour or more of physical activity, and 0 sugar sweetened beverages. And that's great advice. And those are really good goals to work toward. However, it could be that a patient comes in and you talk about obesity and you hand them the 5-2-1-0 handout, and they may look at it and say, I can't afford 5 servings of fruits and vegetables a day. My school is online, so I'm online, well more than 2 hours per day. I'm already doing a sport and I don't drink sugary drinks, right? So it can be a total no hitter for some patients. And if you haven't asked those questions, you may not know that. And then again, that's something that kind of decreases trust for the patients and they feel like maybe there is nothing that will help them. So if you're giving those kinds of tools, I just always like to kind of let the family know that you understand they may be doing some of these things already or that some of them might not be reasonable. If you can specifically, commend them saying, I know that you're not doing any juice or sugary drinks, so this one is nailed. What about these other ones? These can be useful tools. I don't want you to avoid giving handouts in this type of advice, but try to individualize it to the patient so that they feel heard and respected. Okay, so those are kind of my 5 different tips for navigating these difficult conversations. I knew that we would have a little bit more time today, so I included 2 more slides just as something to talk about that I don't think, they won't come up every time that you're having a conversation about weight or obesity, but they come up often enough that it's worth kind of considering and being prepared to talk about these things. So the first one is that, we want to be ready to talk with our patients about BMI, because if you don't know, BMI is a hot topic and it's very controversial. And there are a lot of people and groups who want to do away with BMI altogether. And they'll tell you, this is a racist measure. It's not valid for all people. It's not measuring what it says it's going to measure, right? It tells us nothing about a patient's adiposity. It's not a good marker of their health. And sometimes when we start to talk about BMI in the office or we show the growth curves, patients will jump on you and they kind of want to take you to task about this. And what I find is most helpful is if you can acknowledge the things that they're saying, and usually there's a lot to agree with. I'm very open and quick to tell families that I agree BMI is a very imperfect tool and it doesn't tell me anything about your child's health. But it is a tool that's useful for us. And that's because the other ways that we can diagnose overweight and obesity or specifically look at adiposity are expensive. They take a long time. They take special equipment that we don't always have. Where the BMI is quick, it's accessible, it's cheap, it costs us really nothing, and it's useful as one piece of a big picture when we're looking at your child. So I tell people if the BMI is elevated, it tells me I need to look closer. Maybe we need to do some labs to look at metabolic markers and things that are going on. I definitely want to talk more about your activity and your nutrition. We may do something like a waist circumference. We're going to pay close attention to the blood pressure. So the BMI is a tool that can spur us to look into these other things. And then it also is helpful as to give us an idea of how things are changing over time. So when we use the CDC growth chart, we can see the trajectory of the BMI, and that is way more important than what the actual number is. And I think sometimes families can understand that and buy into that, but I think we shouldn't defend BMI as the end all be all, but be really open and understanding that it has flaws, but it's still a useful tool. And so, I be interested if we have time and conversation if people have had these kinds of discussions with families and what your experiences have been. But I think usually people are pretty receptive to it once they understand that you're not putting all your chips on that BMI number. The other kind of quick topic or something to consider is, what do you do when your patient refuses to be weighed? So this actually is happening a lot in the adult world. I have had some colleagues in pediatrics who've run into this problem where families are now refusing to be weighed when they come to the doctor. There's actually a little wallet card that I don't know if anyone has seen, but it's a little laminated card that families or patients can carry in their wallet. And what it says is, please don't weigh me unless it's really medically necessary. And if you really need my weight, please tell me why so I can give my informed consent. And on the back of the card, it has some of the reasons why. It says most health conditions can be addressed without my weight. When you focus on my weight, I get stressed, and that's not healthy. Weighing me every time I come in for an appointment and talking about my weight like it's a problem perpetuates weight stigma. And I pursue healthy behaviors regardless of my weight status. And then it references a movement called Health at Every Size. So I don't know if anyone's encountered a patient who has had one of these cards, but it's a conundrum in pediatrics because much of what we do does require a weight. So if you're prescribing medication, antibiotics, or other medicines that are dosed weight-based, you need a weight. If you're monitoring for side effects of medications that are known to affect appetite or weight, you may need that information. If this is your patient's once annual visit and your only chance to capture that growth information to monitor their growth and development, you may need it. But what I would encourage you to think about is if a patient does refuse to be weighed, or they present a card like this, or they talk about it, to try to entertain that and consider if you really do need a weight for that visit. And if it's at all possible to respect this, I think it's okay to do that. If you do need a weight, then explain exactly why, whether it's the medication dosing or what. And you can offer what we call like a blind weigh-in. So you can offer to weigh your patient, but not share the weight or discuss the weight with the patient and the family. And I think, when this comes up, this is like the family's jumping one step ahead of us. So you may have been ready to ask permission to discuss the weight during the visit, but they're coming right in off the bat and saying, I don't want to talk about this today. This is not the reason I'm here. And so, I think that just kind of thinking about this and being prepared for it and maybe talking to your staff about it, I would always encourage you to try to consider if you can respect this wish. And then if not, being really clear with the family about why. But certainly this is a family where you're not going to want to necessarily focus much on it unless it's necessary. You want to make sure that you're addressing their health concerns and the reason that they're there. Okay, so I'm going to circle back to the patient comments, and we don't have to spend too much time on this, I don't think, but we'll look through each one and just see if there are any of the tips or techniques we talked about today that are specifically applicable. So this one is the healthy, well-rounded, smart, capable, high-achieving child, eating well, 4.0, standout athlete, active 6 or 7 days a week. Every single time we see this provider, it's uncomfortable. She preaches and lectures, says things that make my child uncomfortable. So, I think when I read this, what I'm thinking is that this is a prime opportunity for the provider to ask permission to discuss the weight, because this is a family that would have said no. It sounds like it's been brought up every single time and that they dread this. And so, if they had an opportunity right off the bat to say, no, I don't want to talk about that today, that would save everybody a lot of stress and discomfort. And again, it's okay. You don't have to talk about it every time. There's no indication in this comment about what language or words the provider used, but it's possible that they used some of that stigmatizing language. So that's something to think about. And then the other thing I see here is that she preaches and lectures, and that doesn't sound like motivational interviewing, right? It's kind of the antithesis of motivational interviewing. So with this family, if it is something that's being discussed, taking more time to inquire and ask about their habits. It sounds like they're feeling the need to lay them all out there in the first sentence because maybe the doctor didn't even ask if they were in a sport before they recommended that they do an hour of activity each day. So hearing them and what they have to say, and then trying to give them more specific goals or encouragement would be more helpful than the preaching and lecturing. In this one, this is the patient who's crying for the entire appointment. The doctor told her she was overweight. So unprofessional for him to say in front of a child. If he had serious concerns, I should have been spoken to in private. So clearly for this one, two things: overweight. This family really didn't appreciate that label or that term being used. So he may have swapped it out for something like she's gaining too much weight for her health, or her weight is too high for her health. That might have been better received. If you ask permission, and then, another thing, maybe I neglected to say this earlier, but your patient might have their own words that they're comfortable using, and it might not match what's on that chart. So it's always appropriate to ask your patient, what words are you comfortable using to discuss weight? So that could be kind of the follow-up to, is it okay if we address your weight today? And what words are you comfortable using? That way there's no risk of giving a label or using a term that they'll find offensive. This is also one where if you asked permission to talk about the weight, the parent might have let you know that's okay, but talk to me in private. Let's not do it in front of the child. And so that would have helped to gain more trust and satisfaction. And that last one, I don't appreciate my daughter's perfectly healthy weight being discussed in front of her like she's 600 pounds. Not everyone fits into your BMI box. So BMI is brought up here. Maybe that's something that there was or wasn't an opportunity to discuss, to acknowledge the imperfections, constant harassment. So it sounds like definitely with this one and the first one that this is a topic the family's hearing again and again. So again, if you take time to ask permission, the family might decline on that particular visit if they're not prepared or interested in talking about it. And that can help. And here it says talking about it in front of her. So maybe the family would have been okay talking about it without the child present. The last one I put in, I guess it's kind of a joke, but this is a patient comment that I have received and I treasure. I think it's actually one that meant a lot to me. And this wasn't as bad as I thought it was going to be. And I've heard that more than once, but the one that stands out in my mind was a teenager who came in with her mom, and at the beginning of our appointment she would not look at me, she would not talk to me. It was clear that she didn't want to be there, but we persisted and kind of used some of those skills and techniques to talk about this subject. And at the end of our long visit, she kind of looked at her mom and she goes, that really wasn't as bad as I thought it was going to be. And they laughed and kind of smiled a little bit and scheduled another appointment. So I think it shows that, our patients, even if they're coming into this with prior bad experiences, it's never too late to turn that tide, and we are able to help make them more comfortable having this conversation. So I wish you all luck in trying these different tips and just practicing, and hopefully you'll see things, feel a little bit more comfortable. Here's my information. I am happy to take questions. I think we've got a little bit of time right now. I feel like I'm blind because I can't see the chat right now or anything. So I don't know if there are any questions there that we can address, but I'm happy to talk offline or after the presentation. Feel free to email or message me if you want any resources or the websites that I talked about today. So Javi, should I advance the slides or stop screen sharing, or what do you want me to do now?
We will have you continue to share while people come up with any questions, should they have any. There is a question in the chat about whether or not there'll be a link to rewatch and listen to this presentation. There will be one in a couple of days. This will be posted on the Ohio AAP's website. I will share that link where it will be in our follow-up email with information about how to claim CME and MOC. If anybody has any questions for Dr. Walston, feel free to unmute yourself and ask. We are getting, I don't know if you can see, a lot of thank you, and this was very helpful in the chat. So this has been a great presentation.
I have a quick question. Can you hear me?
Yes.
This is Deanna. In terms, I know earlier you spoke about, locating your local hospital or, for resources, do your own research first. But are there any other tips about referrals in addition to
Yeah, I mean, I think generally what I would think about is for most patients, it can be appropriate to start doing the obesity care in your office with the primary care doc. Some offices have some additional specialties, kind of maybe you have a dietitian who's at your office or a mental health counselor who might be able to help. So think about that kind of as a next step. And then looking at nutrition, dietary things. In Columbus, I know we had an excellent program for improving physical activity for kids. If somebody wants to, I'm blanking on it right now. Play Strong, I think, maybe.
Correct.
Okay, so there may be things like that you can find that would be ways to refer them for more activity, whether it's kind of health based or community based. And most of the, I think, children's hospitals have these kind of multidisciplinary programs. You don't, it's perfectly appropriate as well to refer right away at your first meeting with a patient, especially if you think that they may be eligible for weight loss medications or bariatric surgery. There's no need. This was an important update in the AAP practice guideline. There's no need to do a staged approach or to wait. You can immediately refer a patient for the highest level of care that would be appropriate for them. So that's, I guess, just another tip on referrals, is if you think this might be helpful for your patient, don't hesitate to refer them. Many programs as well will be able to do some degree of telehealth. So we certainly, at my program, we don't want to do all of our visits telehealth, because then we're losing a chance to get some of those important physical exam metrics and really following the weight. But we don't need vitals every visit. And much of what we do is talking and conversation. So if your family is hesitant to commit to an intensive lifestyle program that's far away from home, that's at least a helpful piece, is that some of those visits could be virtual.
Thank you.
Hi, this is Dr. Sarah Adams from Akron Children's, and this is less of a question, but just a comment for everyone to just note. I've had the opportunity to be educated, for Dr. Walston, and I'm so thankful that you're doing this today. But I want to say that I really have made it a practice to ask, would it be okay if I show you the growth chart? And, we talk about the weight. And I will say that most families are really receptive and appreciate so much. So even if you just start somewhere and, like something like that, I have found in my own practice, it has really been helpful. So I just want to thank you for all of this information.
Thanks, Sarah.
We have one comment in the chat that says some families don't mind that the kid is weighed without being told the weight.
Yeah, I think that's always an option. And even in our obesity treatment program, we don't always, we let the patients decide if they want to know their weight, because usually our actual goals that they're working on are not for an amount of weight loss. They're nutrition goals or activity goals or sleep or lifestyle. So we follow the weight, but they don't have to know it necessarily. And so that's certainly an option that you can give. I think with a lot of this, the more that we can make our patients feel comfortable, the better their outcomes will be, because they will trust us and they'll be more likely to try to, follow through with recommendations and follow up with care and appointments if they feel comfortable and respected.
Thank you so much, everybody, for asking questions and being such engaged participants. If you could advance to the next slide, I would appreciate it. Thank you so much, Dr. Walson, for leading such a great training today, and thank you all so much for coming. Please check your email to claim your CME and MOC credit. We do ask that all participants complete the short survey, even if you do not plan to claim this credit. This will enable us to collect endpoint data to measure the rigor of our programming. Once you've completed the survey, you will receive a certificate within 10 days. I will follow up with these directions via email for your reference. You can go to the next slide. If you like today's training, the Parenting at Mealtime and Playtime program has another 1-hour training on March 20th, where Dr. Sarah Adams will be sharing her expertise on social media use in preteens and teens and how to prepare for and prevent cyberbullying and mental health challenges in young social media users. You can sign up for this training at the QR code linked on this slide. Go ahead to the next slide. If you have any questions or suggestions for future PMP programming, please call or email me, the program manager, at the contact information listed here. And this concludes today's training session. Thank you so much for your time and energy, and I hope to see you in a future Ohio AAP program. And please feel free to download our PMP app. Thank you so much, Dr. Walson.
Thank you.